All right, today we are diving deep into one of the body's most amazing and, honestly, underrated organs, the kidney. We're going to cover the whole story, from its core jobs that literally keep us alive to how we actually check on its health, and then what happens when things go wrong, both in a flash and over the long haul. This is a real masterclass, so let's jump right in.
So here's the plan for today. First up, we'll get into the kidney's core functions. And trust me, it's way more than just a filter. Then we'll look at how we measure renal function, put some numbers on it. After that, we'll tackle the big clinical topics, acute kidney injury, or AKI, and chronic kidney disease, CKD. And to wrap it all up, we're going to focus on something called proteinuria, which is a major clue that the kidneys are in trouble.
Okay, let's kick things off with Section 1, the kidney's core functions. And yeah, I called this more than just a filter for a good reason. Because, look, everyone knows kidneys clean the blood, right? But their real job, their role in keeping our entire body in that perfect, delicate balance, what we call homeostasis, is so much more intricate and, frankly, absolutely vital.
I mean, just look at this list. The kidney is a total master regulator. It's in charge of our water and electrolyte balance, which in turn controls our blood pressure and the fluid outside our cells. It's the body's main waste disposal system, getting rid of metabolic junk and foreign stuff we ingest. But get this, it's also a hormone factory. It regulates red blood cell production with a hormone called erythropoietin. It activates vitamin D to manage calcium and phosphate. It's like a chemist, meticulously keeping our body's pH just right. And if that wasn't enough, if you're fasting for a long time, it can even start making new glucose to keep you going through gluconeogenesis. It is, without a doubt, a multifunctional powerhouse.
So where does all this magic begin? It all starts with filtration, and that happens right here, in this structure called the glomerulus. You can see it in panel A. Think of it like this. Blood rushes in through this wide pipe, the afferent arteriole, swirls through this incredibly dense tangle of capillaries, and then gets squeezed out through a much narrower pipe, the efferent arteriole. That pressure difference is key. It literally forces fluid out of the blood and into Bowman's space, where its journey down the rest of the nephron begins.
Now, let's zoom way in on the filtration barrier itself, because it is a work of art. It's this beautiful piece of biological engineering with three separate layers. First, the blood hits the fenestrated endothelium of the capillary. It's full of these little windows or pores. Next up is the glomerular basal lamina, which is like a basement membrane. And then finally, it encounters these wild-looking cells called podocytes. They wrap around the capillary with these interlocking foot processes, and that creates the final tiny filtration slits. Every single one of these layers has a crucial say in what gets to leave the blood and what has to stay behind.
So how does this thing actually work? Well, it has two key properties. First, it's incredibly permeable. We're talking about 50 times more permeable than a regular old muscle capillary. That's how it can filter such a huge amount of fluid. But it's also super selective, and it does that based on size and charge. The size barrier is pretty straightforward. Little things up to 4 nanometers get a free pass, but almost anything bigger than 8 nanometers is blocked. But the charge barrier is just as important. The barrier itself has a negative charge. This repels other negatively charged molecules, and the classic example is the protein albumin. Now, albumin is about 7 nanometers, so size-wise, it might be able to sneak through. But because it's also negatively charged, it gets pushed away. It's like trying to force two negative ends of a magnet together. It's repelled and kept in the blood, right where it belongs.
And this slide right here is the perfect illustration of health versus disease. Look at panel A on the left. You see a beautiful, healthy filtration barrier. The podocyte foot processes are all neat and tidy, forming these perfect little filtration slits. Now, compare that to panel B. This is what happens in disease. Those delicate foot processes get all messed up. They fuse together and collapse. When that intricate architecture is destroyed, the whole barrier loses its integrity, and that's when proteins like albumin can start leaking through into the urine. That's a classic sign of glomerular damage.
But listen, filtration is only the beginning of the story. The fluid that gets through, called the filtrate, is then heavily processed by the tubules. Any small proteins or peptide hormones that happen to slip past the main filter are immediately grabbed back in the proximal tubules by a process called endocytosis. Other things, like electrolytes, are meticulously reabsorbed or even secreted using a whole army of pumps, channels, and exchangers. Glucose is a perfect example. It's all actively reabsorbed, mostly by a transporter called SGLT2. But you can think of these transporters as having a maximum capacity. If your blood glucose goes above a certain level, what we call the renal threshold of about 10 millimoles per liter, the transporters get overwhelmed. They just can't keep up, and any excess glucose spills out into the urine.
So we have a good handle on what the kidney does. But in medicine, we need to know how well it's doing its job. especially because it can start to fail without any obvious symptoms. And that brings us to our next section, how we actually quantify the kidney's performance.
Okay, the single most important number for kidney health is the glomerular filtration rate, or GFR. You can think of it as the kidney's horsepower. It's defined as the total amount of plasma ultrafiltrate, that's the fluid filtered out of the blood, that's formed every single minute. It gives us a bottom line number for the kidney's raw filtering power.
Now, to measure the GFR, we use a concept called clearance. This can be a little tricky to wrap your head around, but it's super important. Renal plasma clearance is not the amount of a substance that's removed. Instead, it's the theoretical volume of plasma that is completely cleared or wiped clean of that substance in a given amount of time. It's the core principle that allows us to estimate GFR.
And here's the math behind it. This is the clearance formula. Clearance, C, is calculated by taking the concentration of the substance in the urine, U, multiplying it by the urine flow rate, V. That gives you the total amount excreted per minute. Then you divide all of that by the substance's concentration in the plasma, P. It's a really elegant formula, and it's the bedrock of how we measure GFR.
So what substance do we actually measure? Well, in a perfect world, we'd use something called inulin. It's the ideal marker because it's freely filtered by the glomerulus, and then the tubules just leave it alone. It's not reabsorbed, it's not secreted, so its clearance is a direct measurement of the GFR. The problem? Measuring inulin is complicated and just not practical for everyday clinical use. So instead, we use creatinine. Creatinine is a breakdown product from our muscles, and it's a pretty good approximation. It's freely filtered, but it's not perfect. A small amount is also secreted by the tubules, which means it can slightly overestimate the GFR. Plus, someone's creatinine level is really dependent on their muscle mass, their age, and their gender.
Now this graph shows one of the most important and honestly dangerous truths in all of kidney medicine. It shows the inverse relationship between the creatinine we measure in the blood and the actual GFR. Just look at how flat that curve is at the top. What this means is that your GFR can drop by almost half, 50 to 60%, before your creatinine level even starts to budge out of the normal range. This is the critical takeaway. A person can lose a massive amount of their kidney function, and their routine blood work might look totally fine. It's why even a tiny, seemingly insignificant increase in creatinine can signal a huge, catastrophic loss of GFR.
Because of all those limitations with creatinine, we don't just use the raw number. We plug it into special equations to get an estimated GFR or eGFR. Over the years, there have been a few different ones. The old Cockcroft-Gault equation is now mostly just used for drug dosing, especially in chemotherapy. Then came the MDRD and CKD-EPI 2009 equations, which were used for a long time but included a controversial race correction. The equation we recommend now is the CKD-EPI 2021, which has gotten rid of that race correction. There are also newer markers we can use, like cystatin C, but they have their own issues and can be affected by things like inflammation.
And just to make things even more complicated, GFR isn't the only thing that affects these lab values. As this table shows, a whole bunch of other factors can change a person's urea and creatinine levels. For example, a patient's urea might be high because they're on steroids or have a GI bleed, not because their kidneys are failing. It could be low if they have liver failure or are on a low-protein diet. And creatinine? Well, that's heavily influenced by muscle mass, what you eat, or even certain drugs like trimethoprim. So a doctor really has to be a detective thinking about all these other possibilities before they can make a call about a person's kidney health.
Okay, now we're going to shift gears and move into our first major clinical topic, acute kidney injury, or AKI. This is what happens when kidney function gets worse fast. We're talking over hours or days. It is a true medical crisis.
So let's start with the formal definition. Acute kidney injury is a clinical syndrome, and that's a really important point. It's not a single disease. It's defined by a rapid decline in renal function, but it can be triggered by a whole range of different underlying diseases or states.
To try and make sense of all those possible causes, we put them into three main buckets, based on where the problem is. Pre-renal means the problem is before the kidney. It's an issue with blood flow to the kidney. Intrinsic means the problem is inside the kidney itself, causing direct damage to its internal structures. And post-renal means the problem is after the kidney. There's an obstruction blocking the flow of urine out of the kidney. To make sure everyone's speaking the same language, we stage how severe an AKI is using criteria from an international group called KGIGO. As you can see in the table, the stages are based on two things: how much the serum creatinine has gone up from the person's baseline and how much their urine output has dropped over a certain period of time. Stage 1 is a pretty moderate change, but by the time you get to stage 3, you're talking about a very severe injury, a long period of no urine output, or even the need for dialysis.
Let's dig into the most common type first, pre-renal AKI. It accounts for a huge chunk of cases, somewhere between 40 and 80%, and it's all about blood flow. The cause is reduced blood volume or pressure. The mechanism is that the body sounds the alarm, activating the sympathetic nervous system and the renin-angiotensin-aldosterone system, or RAS. The immediate consequence is that the kidney pulls a clever trick to save itself. It uses prostaglandins to dilate the end pipe, the afferent arteriole, to let more blood in, and it uses angiotensin II to constrict the out pipe, the efferent, to build up pressure inside.
And this slide shows perfectly why certain common drugs can be so dangerous in this situation. Look at diagram C. Let's say a person has low blood flow to their kidneys and they take an NSAID, like ibuprofen. That blocks the prostaglandins that are trying to open up the afferent arteriole. The in-pipe can't get wider, and GFR just tanks. Now look at diagram D. Same person, low perfusion, but this time they take an ACE inhibitor. That blocks angiotensin II, so the efferent arteriole can't constrict. The outpipe stays wide open, pressure escapes, and boom, again, the GFR plummets. This is exactly how these drugs can tip someone over into an acute kidney injury.
Okay, now let's talk about intrinsic AKI, where the damage is actually inside the kidney. This slide gives a great overview of the different parts that can be hit. The problem could be in the small vessels, the glomeruli, the tubules, or the interstitium, that's the tissue in between the tubules. For instance, the tubules can be damaged by toxins or by not getting enough oxygen, which we call acute tubular necrosis, or ATN. The glomeruli can get inflamed, and the interstitium can be damaged by things like allergic reactions to drugs.
So a big question in the clinic is, how do you tell the difference between a pre-renal problem and an intrinsic one? Well, we look at the urine. In pre-renal AKI, the kidney itself is fine and it's working overtime trying to hold on to water and salt to fix the low blood volume. So the urine will be very concentrated, it'll have a high osmolality, and it will have very little sodium. But in intrinsic AKI, the tubules themselves are broken. They can't do their job of reabsorbing water and salt, so the urine becomes dilute, it has a low osmolality, and it's full of sodium. This table is a classic diagnostic tool we use all the time.
The treatment really just follows the cause. If it's pre-renal, you get fluids to restore blood flow. Simple. If it's post-renal, you find the blockage and you get rid of it. If it's intrinsic, the treatment is mostly supportive care. We manage the complications and give the kidney time to hopefully heal itself. And if the injury is just too severe, we have to turn to dialysis. The major reasons to start dialysis urgently are things like severe fluid overload, what we call hypervolemia, dangerously high potassium or hyperkalemia, severe acidosis that we can't control, or if we need to remove a specific nephrotoxin from the blood.
All right, let's switch gears now, from the sudden crisis of AKI to a much slower, sneakier problem. Our next section is all about chronic kidney disease, or CKD, which is a gradual, long-term decline in kidney function.
So, the definition of CKD has two really important parts. First, it has to be long-standing. That means the kidney impairment has to be present for more than 3 months. And second, it is potentially progressive. It doesn't always get worse, but it can, and a huge part of our job is to try and slow down or even stop that progression.
And just like with AKI, we have a staging system for CKD, also from KDIGO. Now, what's really cool about this grid is that it classifies a person's risk based on two things at the same time. On the vertical axis, you've got the GFR stage from G1, which is normal GFR, all the way down to G5, which is kidney failure. Then, on the horizontal axis, you have albuminuria. That's the amount of albumin protein in the urine, from A1, which is normal, to A3, which is severely increased. You find where your patient's GFR and albuminuria intersect, and that tells you the risk category from low risk in green all the way to very high risk in red. It's an incredibly useful tool for predicting prognosis.
So what causes CKD? Well, the leading causes around the world are diabetic nephropathy, different types of glomerulonephritis, and kidney disease associated with high blood pressure. But once someone has CKD, what tells us how fast it's going to get worse? There are 3 big factors that point to a worse prognosis: poorly controlled hypertension, the amount of proteinuria, and how much interstitial scarring or fibrosis we see if we do a kidney biopsy.
That last point, proteinuria, is so unbelievably important that we're going to spend our entire final section on it. Understanding where protein in the urine comes from and why it's such a big deal is one of the most critical concepts in all of nephrology.
As this diagram shows, protein can show up in the urine for a few different reasons. You can have overflow proteinuria. This happens when there's just so much of a small protein in the blood, like Benz-Jones proteins in multiple myeloma, that it overwhelms the kidney's ability to reabsorb it all. Then there's glomerular proteinuria, which is the most common kind. This is when the filtration barrier is damaged and it's leaking bigger proteins like albumin. You can also have tubular proteinuria, where the tubules are damaged and they can't reabsorb the small proteins that normally get filtered. And finally, some proteins are actually secreted by the tubules themselves, like TAM horsefall protein.
When that glomerular protein leak becomes really massive, it can trigger a full-blown clinical state called nephrotic syndrome. It's defined by 4 key features that all follow one another logically. First, you get heavy proteinuria, more than 3 grams a day. All that protein loss leads to the second feature, a low concentration of albumin in the blood. When your blood albumin gets low, you can't hold fluid in your blood vessels, which leads to the third feature, massive swelling or edema. And finally, for some complex reasons, the body's response to all this also leads to hypercholesterolemia or really high cholesterol.
So to diagnose and manage these conditions, we have to be able to accurately measure how much protein is in the urine. The old gold standard was a 24-hour urine collection, but that's a real pain for patients. So these days, we more often use a spot urine test and calculate a ratio. The urine protein to creatinine ratio, or UPCR, gives us a good estimate of total protein. The urine albumin to creatinine ratio, or UACR, is more specific just for albumin, and it's super sensitive for picking up early glomerular damage, especially in patients with diabetes. This table here just gives you a rough idea of how these different measurements line up with each other.
So we've really gone on a journey today, haven't we? From the incredible, elegant design of the filtration barrier through the clever physiology of how the kidney protects itself and all the way into the clinical world of acute injury and slow, chronic decline. It's an amazing system. So I want to leave you with a final thought to chew on. From the elegant design of the filtration barrier to the slow progression of CKD, how does understanding this entire pathway, from the cell all the way up to the syndrome, really change our approach to preserving kidney health, both for ourselves and for our patients?